It's always a pleasure to talk about research, and this is an excellent opportunity for you to start exploring your research interests and also building on them throughout the years of your studies. I am an assistant professor in biostatistics, epidemiology, and research methods. And just a little about my background. I have a degree in statistics. I have a master's degree in biostatistics and a master in managing crisis in the public health sector. My PhD is on environmental epidemiology, and my postdoc thesis was on developing statistical models as to predict individualized air pollution exposure assessment, incorporating information and applications from GIS systems. So when I was a student, I had the privilege of participating in a large European center study on the health effects of air pollution, the FEA project. This was a highly motivating experience since I had the chance to apply what I was learning in the classroom to a real situation. And the findings of this study brought new funding for research projects. And together with the work of other researchers, this led to major advances in public health policy. The first one was in 2013 when the International Agency for Research on Cancer announced that it classified exposure to outdoor air pollution as group 1 direct cancer causing, especially for lung cancer. And the second one was in 2021 when WHO released updated guidelines on outdoor air pollution exposure levels, emphasizing that even lower levels of air pollution are harmful to human health with the potential of saving millions of lives globally every year. So together with my previous work on these projects and combined with my studies, my research interests are mainly focused on applied biostatistics, environmental epidemiology, health impact assessment, and meta-analysis. All of these focusing on promoting public health. Today, we have shifted towards studying the exposome. The exposome represents all external, meaning different environmental factors, and all internal, meaning our personal lifestyle characteristics that interact with the body to produce biological responses that influence both health and disease. And this is done across the whole life course, from conception to death. So all this is summarized in one central question. The question is, how can we maximize health in a modern urban environment? This is a holistic approach which completely is in alignment with our university's core concept of One Health. My research focuses mainly on the external, so in the context of environmental epidemiology, the urban exposome represents the totality of exposures that we experience from climate-related exposures, meaning things like increased temperature, extreme events such as heat waves, cold spells, droughts, floods, dust episodes, and wildfires. Also on air quality, studying regulated air pollutants, but other novel ones like chemical components, metals, PAHs, and black carbon that have been studied, and they seem to be more toxic and more harmful than other air pollutants. Also, we are interested in studying the built and social environment. Studies have shown that close proximity, easy access, and visibility of green and blue spaces like parks and the sea have advances for mental health and in general well-being. These are also places that we can do physical exercise. On the other hand, exposures such as light at night and transportation noise from different kinds of sources can be annoying, and also have shown that to elevate blood pressure measurements and also triggering the mechanisms as to develop cardiovascular disease. The other thing that we are interested in studying is the food environment, meaning what? Meaning if we work or live in places that we can buy easily fresh fruit or vegetables, as in contrast to having places that sell many unhealthy snacks and junk food. And also area level socioeconomic factors, meaning that if we live in a neighborhood that is more deprived, say has a high unemployment rate or a low education level, these also are things that promote health inequalities. So in the framework of the Expanse project that is European funded and is a Horizon project, we have mapped at a pan-European level all these exposures and are now studying the synergistic and the cumulative effect of these exposures on human health. Also, there's an ongoing, again, Horizon program that is MedClim, which is focused on Mediterranean countries, since climate change is increased in these countries. And also, we have instituted a national observatory. This is funded by the Initiative 21 members. This national observatory is in Greece, and it monitors health effects from climate change at real time, and also does predictions based on future climate scenarios. However, there are more emerging environmental exposures, and top of the list are micro and nanoplastics. These are very small particles, and just to have a relative idea of their size, the human hair has a diameter of 80 microns. A grain of sand has a diameter of 90 microns. Microplastics are less than 5 microns, and nanoplastics have a diameter less of 1 micron. So they are practically everywhere due to plastic breakdown from larger pieces or from products that were manufactured for this purpose, like fibers and clothing, and from cosmetics. They are mainly found in water, also in soil, and then in the food chain, and also in the air. We are mainly exposed through ingestion and also breathing, and they also, since they are very, very small, they penetrate the skin. Studies have detected microplastics in the blood, and the smaller they are, the more easy it is to travel through the bloodstream and reach organs such as the brain and placenta. They have also been detected in urine, breast milk, and sperm. We are very interested now to investigate the possible effects of micro and nanoplastics because they may contain chemical components that are very harmful, and they have the potential to induce via inflammation and oxidative stress different kinds of toxicities. We have a few months ago, we submitted a proposal at this open call about advancing knowledge and the impacts of micro and nanoplastics on human health. This is also a Horizon project, and we are waiting for the decision. Hopefully, it will be funded. In the past, we used aggregated data to do all this research work, but now we have shifted towards individualized exposure assessment. This means that we predict individual exposures across different microenvironments based on the home address, the work address, when we are in transit, using a plethora of tools. I mentioned before that we use GIS, which are geographical information systems used for geocoding addresses, collecting GPS data to access mobility patterns, and also mapping exposures. And since other scientific fields have also advanced, we have the computational power to apply advanced biostatistical methods to develop hybrid spatiotemporal models. Spatiotemporal means that we develop statistical models that can predict in any point in space of the study area and in any point of time during the study time period, while hybrid refers to combining, integrating data from different sources like satellite images, remote sensing platforms, measurements from fixed monitoring sites, data that we can download from personal wearable devices, and also using the predictions from different type of models, not statistical, let's say deterministic models, such as chemical transport or dispersion models. Since we are talking about public health, we are basically interested in all health endpoints. So we start from all natural causes of mortality. There's many studies done on the effects of the different environmental exposures on cardiovascular and respiratory disease cause specific mortality. Neurological and mental disorders haven't been studied so much, so we are focusing on these outcomes now. Also cancer and COVID-19, which now has its own ICD code. And the same stand for morbidity outcomes, plus preterm births and admissions to neonatal ICU for prematurity, since we said before that all these exposures from embryonic life affect us. I also have expertise on analyzing large-scale data to study short and long-term health effects involving different study designs, like traditional cohorts, which recruit thousands of people, mega cohorts, and administrative cohorts that are population-based or combine many cohorts together. So we are talking about millions of observations. Biobanks are very useful because they collect, store, and manage biological samples. Registries, like cancer registry, time series, where we can get high resolution data usually from statistical authorities to study temporal trends, and community-based intervention studies. I also specialize in health impact assessment. This is a method used to estimate attributable or excess cases of deaths. This is very important for disseminating the findings, and it provides evidence in a simple way for stakeholders because they are the people that make the decisions for public health, and also informing the public using plain language. Meta-analysis after conducting a systematic review. And I would just like to say that research is a result of a team effort and hard work. If you are interested, you must start by studying the literature and by developing your critical thinking skills. And even if you're not interested in the specific things that I presented, if you have an idea, if you are collaborating with another fellow professor, I am very happy to help out with a research protocol, study design, or the analyzing of the data. Finally, I have selected a couple of research papers that I have co-authored, starting from the most recent and going to the bottom of the list, which these are the most influential papers. They are published in journals with a high impact factor like the Lancet, Lancet Oncology, European Heart Journal, if someone has to take a look. And by scanning this QR code, you can download my presentation to have time to study it. And I'm very happy to discuss if anyone has, yeah, it's not an absence, it's not a QR code for absence. Thank you. So I think we have time for questions at the end. Okay, so Dr. Liouta. Puedo minimizar. No.
Okay, good morning to all of you. I really thank organizers for this event. Sorry to say that I do not have a scan for you to obtain the slides, so pay as much attention as you can. So before I start talking about research, I would like to introduce myself once again. So who is Evangelia Liouta? I obtained my bachelor in psychology from Greenwich University in London. Afterwards, I obtained my master's in degree in neuropsychology from the University of Bristol, and that was the year that I got my first publication on personality traits and some visual spatial deficits. I would like to say that having the first publication with your name written on it, it's a very important moment. I still remember that was one of my happiest and cheerful days. So I wish you to have the same feeling as soon as possible. Afterwards, I obtained my PhD in the medical school of University of Tübingen in the neuroradiology department. You will see later a part of my dissertation that has to do with tumor patients and advanced MRI techniques. So after my studies, I returned to Greece, and since 2008, I was based in the Department of Neurosurgery of the University of Athens that is located in Evangelismos Hospital. The first 4 years, I was involved in research as research assistant, and I was implicated to one of the most ambitious project that I've been involved in. That's the mind-to-mind communication, brain-to-brain communication through computer and through transcranial direct current stimulation. One of the application of those techniques was to see whether we can change consciousness disorders through a direct current stimulation, and also some movement disorders. It was one of the first papers, it was the first paper in the world touching a very, very hot topic, that of vegetative state at coma patients. During that period also, I was involved in epilepsy research with cognitive deficits, studying cognitive deficits and trying to lateralize and localize the seizure of our patients. And also I was involved in the cognitive assessment of patients with deep brain stimulation. Deep brain stimulation is a method of implanting an electrode in patients with movement disorders such as Parkinson, and not only, for therapy. And almost 13 years ago, it was a milestone of my career. Neuropsychology was for the very first time in Greece established as a unit in the neurosurgery departments in the whole country. Of course, Professor Stergios, professor of neurosurgery at University of Athens, was responsible for this. So neuropsychology became one of the sections, was established, the first neuropsychology unit in neurosurgery in Greece. Also, the last couple of years, we have cooperation with the hospitals that we are affiliated, such as Metropolitan Hospital with Professor Stavrinou in neurosurgery, where we assess patients with brain tumors, and we do awake craniotomy. So in the clinical placement, you might see me in some of those operations. And finally, we also have cooperation the last couple of years with Υγεία Hospital, with pathological clinic, the Gamma Pathologique Oncologique Clinique, where Dr. Evangelia is the director, and we study quality of life in patients with gliomas. So this is my clinical and research work that has to do major with neuro-oncology. My expertise is the cognitive deficits and the neurocognition in neuro-oncology, the neuroanatomy and function of white matter of the brain that is related to brain tumors, and the third one is the normal pressure hydrocephalus. So, beginning with the brain tumors, I'm interested in using advanced techniques such as resting state fMRI. fMRI is resting state fMRI is technique of MRI that we can map functions such as language, motor, and we apply this, and you can see in MRI in order to see how. I don't know if this.
The pointer also in the presentation.
I think I did something wrong. Aphrodite. Sorry for that.
Charge related. Aphrodite, you can give a pointer from the presentation. It's below the slide. You can gather.
Here, so.
Pointer holds it. Are we here?
Think so.
Let me do that.
Okay, so sorry for that. We applied, as you can see, this lights up. We apply some statistical methods in order to map language and motor areas in relation to some lesions. You can see here a tumor. The main point is that, and this is my expertise in neuro-oncology, is because patients with cancer, with brain tumors have, some of them have a lot of years in overall survival. Aim of the modern neuro-oncological surgery is not only to maximize the survival, the overall survival, but also at the same time to minimize post-operative neurological deficits. So our aim is to protect those functions and prognose how patients, their function is going to be after treatment, after surgery, or after radiotherapy, after chemotherapy. So one of the first, my first publication was the effects of intracranial meningioma in patients. Was the first one in international literature showing that meningioma patients indeed have cognitive deficits, but surgery does not have any negative impact on their function. So it was a safe procedure. Also have lots of publication on gliomas. Gliomas are intraparenchymal lesions, tumors, malignant ones. Again, we indicated that the majority, 80% of patients have cognitive deficits, and preoperative assessment help us to understand and prognose their postoperative status. I'm sure you know about awake craniotomy. I've talked to you about this during our lecture. It's one of my expertise. Here you can see a case where we try to map the exact area, the exact white matter pathway of the brain when we have task of visual spatial processing. Also, we run some association between preoperative neurocognitive status and some biological markers of high-grade glioma, showing that the most infiltrative the tumor is, the most the neurocognitive deficit, the clinical status is declines in our patients. And last but not least, we have shown that neurocognitive function is an independent survival prognostic marker in glioblastoma, which is the most malignant tumor of the human brain. So the second, my expertise, the second expertise is normal pressure hydrocephalus. Here you can see the ventricular system of the brain, which is enlarged, and this is what we call hydrocephalus. There's a lot of cerebrospinal fluid. There's a lot of water, in very simple words, in our brain. And my research has to do with the phenotype of hydrocephalus patients as one clinical deficits is the cognition. And the last one is the anatomy in cooperation with the Athens Microneurosurgery Anatomy Lab. We have published a lot of papers in dissection of white matter, gray and white matter pathways. We talked on lectures about all these brain networks and how much complex they are, and they are connected with white matter pathways. So in these cases, we try to reveal, even discover new white matter pathways and discuss about their function in the brain. So all this research I presented you until now is continue to have like 10 projects that run now. What about the future? Since last year, I'm a member of the cost action proposal. The NeuroX Rehab cost is an action that more than 30 countries in the world are involved in on neurorehabilitation. And last but not least, last year I was honored to be neurocognition committee member of the brain tumor group of EORTC. EORTC is the European Organization of Research and Treatment of Cancer. So I'm in the committee, and our aims are to evaluate current neurocognitive testing tools, to recommend and develop neurocognitive testing tools. We are going to publish our new guidelines in a few months for CNS tumors such as gliomas, meningiomas, metastases. Also, we're going to assess what is the effect of chemo and radiotherapy on cognition, and to optimize implementation of neurocognitive assessment in brain tumor group trials. So this is all for me. Thank you for your attention.
Να βρω την ομιλία. So hello everyone, I'm Stergios Douvetzemis. I'm a breast surgeon and I'm the director of the Department of Basic and Clinical Sciences here, a clinical associate professor. As I said, I'm a breast surgeon, so my main interest is clinical. I deal with patients all the time. I treat breast cancer patients and patients with benign breast disease. So any research focuses on that. I'll try to tell you what perspectives we have in our department at the moment, in case you would like to get involved in something. So regarding me, I was a consultant at Guy's Hospital in London and a senior lecturer at King's Medical School in London. And I'm an examiner in the European Board of Breast Surgery that we give to the official certification to all breast surgeons in Europe. We examine them and they get the certification from us. So, as I said, my main focus is on clinical research. So we study clinical outcomes and decision-making process in patients with early breast cancer. You see a patient with breast cancer, you have to decide what is the optimal treatment, and you have to see whether this treatment worked better than another treatment. We need to see which are the most effective drugs for breast cancer, most efficient ways for wound healing in high-risk patients. When you operate on a patient, you want the patient to have a good wound healing and go home without complications. So are there any ways to enhance that? As a surgeon, of course, I care about that. And also about anatomical variations during breast and axillary surgery, which is the field that I operate on. Actually, this was my PhD as well. So a study that has recently been launched in our department, I'm the PI in our hospital, is Prelude. This is a prospective multi-center registry about treatment, clinical outcomes, and decision-making process in patients with early breast cancer who are eligible for molecular assays. What is this? So when we have a patient with breast cancer, if we know there are some criteria, in some cases we know that this patient definitely needs chemotherapy. If we know that, we give chemotherapy. 70% of early breast cancer cases might safely avoid chemotherapy. Until some years ago, this was a clinical decision. So we would sit down all together in a multidisciplinary meeting and we would vote. And we would say this patient, we feel that she does need chemotherapy. Now it doesn't work like that. Now, if a patient is eligible to avoid chemotherapy with breast cancer, this can be proved by a molecular assay. So we analyze the genes of the tumor, not we. We send the tumor to a special lab in the States, in USA. They analyze the genes of the tumor itself, and we get a score. If this score is high, then the patient needs chemotherapy and she will benefit from that. If the score is low, then the patient does not need chemotherapy and she will not benefit from that. So now this is precise medicine. And now we see, based on the decisions that we make, whether these patients do well or not. We have a specific criteria. I don't think that there's any meaning to speak more about that. We also ran 5 trials about testing drugs. We have the traditional drugs that we use in patients, and we have new drugs that have passed phase 2 studies, and now they're in phase 3 studies. So we can use them in large-scale populations and see whether these new drugs, which are promising, work better compared to the traditional medication that we have. Usually they do work better, so usually giving the chance to a patient to get a new drug is better for the patient. That's why in most guidelines it says that the best treated patients are patients enrolled in a clinical trial. So we have to give our patients the option to try new drugs that, from studies that we had until now, in smaller scale studies, they worked well. But of course, they also have side effects. So this is something that we have to test as well. There are a couple of studies. I don't need to tell you more about those things. So we run studies about these things. They're commercial studies. We check whether these drugs are working well or not. Something else is about wound healing. As I said, we have published already this PICO mechanism, which has become, after our study, has become mainly a guideline used in the UK. So in high-risk patients for wound healing complications, if we use a negative pressure dressing for a week after surgery, we had fewer complications, but we just compared this to what was considered as okay from the Association of Breast Surgeons. So they said that for this type of operation, you should have up to this amount of complications. By using this device, we had fewer complications than that. Now we're planning to start a study to randomize patients with the same characteristics and see if we use this and we don't use it, is there a difference? So to have a better evidence about what we have found. Of course, as I said, my PhD was in anatomical variations in the field of breast and axillary surgery. During surgery, sometimes we might see things like that. This small muscle here is called sternalis muscle. This is an anatomical variation. We don't usually have it. It might happen occasionally. It's something benign. It's not a problem. But sometimes it might confuse you during surgery, and sometimes it might even mimic cancer. So we have to be aware of those things. When we see them during surgery, we keep a note of them and we publish them every now and again. And these were some publications from anatomical variations in cadavers and in patients. And also, of course, we study with reviews things that are not clear. In breast surgery, for example, we have some things called intramammary lymph nodes. 1 out of 3 patients usually have a lymph node in the breast. We usually have the lymph nodes in the axilla. 1 out of 3 have lymph nodes in the breast. These are normal things. But if a patient has breast cancer, there is no clear evidence about what we should do with these lymph nodes. Should we sample them? Should we remove them? Not usually. Should we ignore them? So we try also to just to review evidence in the literature from things like that. So my main interest is clinical, more simple compared to what you have heard. If you would like to get involved in gathering information, in writing things, in coming closer to patients, you are more than welcome to contact me and come in our department and help in those things. Thank you very much.
So, hello. I think you all know me, but I am Dr. Eleni-Kyriaki. I am an assistant professor of anatomy. I'm also a pediatrician. My PhD is in anatomy, and I also have a Master of Science in Developmental and Adolescent Health. I have been for over 10 years a teaching and research associate in the Department of Anatomy in the Medical School of National Kapodistrian University of Athens, and I have also been teaching and research associate at the last 5 years in the second department of pediatrics in Medical School of National Kapodistrian University of Athens. So I would like to start by presenting my research interest, which of course mainly focus on anatomy, meaning gross anatomy, neuroanatomy, developmental anatomy, and because I'm also a pediatrician, my interest includes as well pediatrics, developmental, and adolescent health. So I thought it would be important to define anatomy. So anatomy, human anatomy, is the scientific study of the structural organization, composition, and physical relationships of the human body parts, ranging from cells to organ system. We can divide anatomy in gross anatomy, which is actually the study of structures visible without magnification, such as organs, muscles, vessels, arteries, veins, and bones. Microscopic anatomy is the study of fine structure, including tissues and cells, and actually is mostly a part of histology and cytology. And an important field of anatomy is neuroanatomy, which is actually the study of the anatomy of the nervous system and mostly the study of brain anatomy. So in conclusion, anatomy focuses on the structure, development, and form of body parts. And we can say that anatomy is a fundamental science for medicine and health sciences. So, do we all have the same anatomy? Basic anatomy, yes, but as we are different individuals, we might present anatomical variations in our body parts, meaning muscles, vessels, arteries, veins, nerves, and other features. Every clinician should be aware of these anatomical variations in order to perform surgical procedures, imaging techniques, and to plan therapy. On the other hand, recent research, and according to recent research and available literature, there seems to be a high correlation between the anatomy of the brain and neurodevelopment disorders such as ADHD, meaning attention deficit hyperactivity disorder, ASD, autism spectrum disorder, Huntington disease, or Parkinson. So I believe that it's very clear why anatomy is an important field of research. In addition with what I have just already mentioned, I'm presenting a recent publication. It has been conducted with the collaboration of the Department of Anatomy of School of Medicine of National Kapodistrian University of Athens. The title is Connection between Prefrontal Cortex Anatomy and Autism Spectrum Disorder. According to our findings, the anatomy of the prefrontal cortex appears to play a crucial role in the pathophysiology of ASD. And I would like to point out again that this is an initial study. Now, moving on, I would like to present some upcoming research projects of the Department of Anatomy. We mostly conduct systematic reviews and meta-analysis, literature reviews, classification systems, case reports, and case series. In consideration to classification systems, I would like to mention some of my past research projects. For example, the classification system of the anatomical variations of the celiac trunk, which has been widely accepted as Panagouli classification, and other classification systems, for example, the classification system of the anatomical variations of the renal arteries, the ascending lobar arteries, and others. Now, the first research project I would like to present is the study of amygdala structure in children and adolescents with neurodevelopment disorders. It's going to be a systematic review. Okay. So, amygdala, what is amygdala? Amygdala is an almond-shaped nuclei which is located deep within the temporal lobes. Amygdala acts as a crucial component of the limbic system. It is primarily responsible for processing emotions and is actually considered a region sensitive to stress and critical for safety maladaptive behavioral responses. The neurodevelopment disorders we are going to study is ADHD and ASD in pediatric patients. Adolescents are of course included, and the purpose is to clarify, to observe, and to highlight any correlations between the anatomy of the amygdala and those neurodevelopment disorders. The next research project is the prenatal identification of aberrant right subclavian artery. It's going to be again a systematic review. What is aberrant right subclavian artery, known as ARSA? So ARSA is an anatomical variation of the right subclavian artery. It's a congenital variation. In this case, the right subclavian artery originates at the last branch of the aortic arch rather than from the brachiocephalic trunk. So let me explain that to you. Here we can see the normal anatomic pattern. This is aorta. As you can see, the brachiocephalic trunk rises from the aorta, and then the right subclavian artery originates from the brachiocephalic artery and moves forward to the right arm. Here we can see the variation. This is the aberrant right subclavian artery, ARSA, which originates directly from the aorta as an independent branch, as a fourth branch, and then it runs either behind the esophagus or between the esophagus and the trachea or in front of the trachea, and then it moves towards to the right arm. In this case, due to this course, we might face complications such as dyspnea or dysphagia due to the compression of the trachea or the esophagus respectively. A little bit of anatomy. So the study objectives will be to highlight the prevalence of ARSA in prenatal population because this variation could be identified prenatally by ultrasound, to highlight the diagnostic accuracy of prenatal detection, to find any association of ARSA with chromosomal abnormalities such as trisomy 21, DiGeorge syndrome, or other cardiac or extracardiac anomalies, and to highlight any psychological outcomes, such as levels of parental anxiety following prenatal diagnosis. Another project is an effort to classify the superficial ulnar artery. superficial ulnar artery is one of the most common anatomical variations of the normal ulnar artery. Actually, it was a case report presenting this variation was my first publication, and it is a very important variation, and I'm going to explain why. Superficial ulnar artery is an ulnar artery of higher origin and the superficial course. It presents various patterns according to its course, its origin, and its coexistence with the normal artery, the normal ulnar artery. And due to this superficial course, it might be injured very easily. It might be mistaken as a vein, and that might lead to accidental intra-arterial injection of intravenous drugs. Furthermore, as you can see here, its presence may be fairly useful if known, as it can be used as a microvascular recipient or donor vessel. So the purpose of this study is to classify all these various patterns. And this one actually is an ongoing project. We're going to work together with Dr. Dimakopoulou and with the collaboration of the team of Professor Chrousos. Professor Chrousos is Emeritus Professor of Pediatrics in the National Kapodistrian University of Athens. This is going to be a meta-analysis as well. And you can see the study objectives to quantify the variation in cortisol levels according to mode of delivery, to assess the statistical and clinical significance of these variations across studies, to explore potential short and long-term implications of differential cortisol exposure for both maternal and neonatal health. So, as you can see, most of the studies are systematic reviews. I know that you have been familiarized with the strategy of reviews, so you are more than welcome to help, for example, in collecting and abstracting data or any other step you would like. And last but not least, you know that next year we are going to work with cadavers. So it's very important to record any anatomical variation we observe. Which types anatomical variations of arteries, veins, muscles, whatever. What we have to do, we have to keep photo records to document measurements, sizes, and other features. Why? In order to publish case reports and to perform classifications. And this is going to be original research, and I need your help in that. So you can access me by email. Thank you very much.
Great. Ευχαριστώ πολύ. Okay, good evening everyone. I'm Charalambos Skarlis. I'm Assistant Professor of Pharmacology. First, I would like to share with you some information about my educational background. I'm a pharmacist. I study pharmacy at the University of Ferrara in Italy. I hold 2 Master of Science from the National Kapodistrian University of Athens, one in molecular and applied physiology, and the other in the clinical trials. Of course, I hold a PhD degree. During my educational journey, I worked in several research projects for Parkinson's disease with animal models, for the Italian vaccine regarding the Italian vaccine for the HIV infection, and several others, as you can see. So during my research, I was trained and I applied several techniques of molecular biology, immunology, handling animal models, a Parkinson's disease animal model, drug test, movement tests, HPLC. I applied ELISA, flow cytometry, several challenges in cells. And the last years, I worked in immunogenotyping of several genes related with the immune system, such as HLA, BAF, and others. So my research interests are focused mainly in autoimmunity, and particularly in the pathophysiology of and comorbidities and pharmacological treatments of systemic autoimmune diseases, including Sjögren's syndrome, myositis, systemic sclerosis, and systemic lupus erythematosus. Of course, the same for autoimmune disease of the central nervous system, mainly pediatric and adult onset multiple sclerosis and neuromyelitis optica. Of course, I'm always focused on immunopharmacology regarding the efficacy and safety of agents targeting components of the immune system. The main aims of my research are focused in the identification of biomarkers, genetic biomarkers, protein biomarkers, in general molecular biomarkers, for disease prognosis, disease course, therapeutic response, associations with disease phenotypes. The last years, I'm working with human samples derived from serum, cells, nucleic acid, and CSF. I'm applying different methodologies, different techniques of molecular biology and immunology, such as PCR, PCR-FLP, real-time PCR. We're trying to apply transcriptomics, proteomics, immunoblot, ELISA, flow cytometry, and other. These are some of the most representative publications from my research. I'm working in several ongoing projects. The first is the investigation of the role of the BAF polymorphisms in the prognosis of anti-JCV positivity and natalizumab-related progressive multifocal leukoencephalopathy. I'll give you some information about that. One of the most efficient treatments for the multiple sclerosis is the monoclonal antibody natalizumab. However, for the patients which are positive for the JC virus, these patients have a major risk to develop progressive multifocal leukoencephalopathy, which may cause the death of the patients. So the aim of the research is to identify genetic biomarkers which could be prognostic for the PML. I'm also working on the safety and efficacy of ocrelizumab in MS patients, on the role of autoantibodies in systemic rheumatic diseases, and currently we perform a meta-analysis collaboration with Assistant Professor Dimakopoulou and my collaborator Myrto Langi in the efficacy and safety of melatonin in the treatment of MS patients. During these years, I have established several collaborations, both national and international. I'm working 10 years with the Genetical Hospital, with the Unit of Demyelinating Diseases, with Professor Anagnostouli. Of course, with the Unit of Molecular and Applied Physiology, with Professor Mavragani. I have established also some international collaboration with Weill Cornell, the University of Ferrara, and the University of Oslo. Regarding the future directions of my research, I aim to investigate more in depth the role of melatonin gene polymorphisms in MS pathophysiology and treatment, to continue my research on the efficacy and safety of B-cell depleting agents in the treatment of MS and NMO patients, investigate more in depth the role of BAF gene polymorphisms in multiple sclerosis, and of course to investigate the role of type I interferons in the efficacy and safety of JAK inhibitors. At last, I always feel the need to thank my professor and mentors from the University of Ferrara, Professor Morari, Gavioli, my friend Francesco Nicoli, who is now Associate Professor in Microbiology, Of course, my professors here at National Kapodistan University of Athens, Mariana Gnostoul and Klioma Dragani, and all of my collaborators, Professor Konstantina Dimakopoulou, Silvia Naftopoulou, Nikos Marketos, Anastasia Chronopoulou, Emanuela Panagiotaki, Myrtola G, Evi Katsaouni, Dimakopoulou, Maria Gondika, Eleftheria Papa. Thank you very much.